Pre-operative preparation in anesthesia includes 1. Investigation. 2. Optimization and risk stratification. 3. Pre-medications. 4. Consent. Minimum cutoff value for hemoglobin of a patient undergoing any surgery. 8 grams per deciliter. Minimum cutoff value for hemoglobin of a patient undergoing any surgery with systemic disease. 10 grams per deciliter. Minimum cutoff value for hemoglobin of a patient undergoing any surgery with severe disease ICU, ventilator. 12 grams per deciliter. Minimum platelet count of a patient undergoing any surgery with regional anesthesia in closed cavity space. 1 lat per microliter. Minimum platelet count of a patient undergoing any surgery with regional anesthesia in non-closed cavity space. 80,000 per microliter. Minimum platelet count of a patient undergoing biopsy, liver, renal. 80,000 per microliter. Minimum platelet count of a patient undergoing any invasive procedure, central catheter. 50,000 per microliter. Indications for platelet transfusion before any surgery. 1. If count less than 20,000 per microliter. 2. HO bleeding. Indication for RFT before any surgery. Chronic kidney disease, nephrotoxic drugs, reduced urine output. Indication for LFT before any surgery. Herbal medicine use, antitubercular therapy history, anti-epileptics history, chemotherapy history. Indication for coagulation studies before any surgery. History of bleeding disorder, massive blood transfusion, warfarin therapy. Indication for urine examination for casts before any surgery. Hyaline cast, proteinuria, risk of kidney injury. Indication for UPT before any surgery. In all reproductive age females. Indication for CXR before any COPD, bullous lung disorder, mediastinal tumor, pneumonia. Pulmonary edema, any positive respiratory finding. Indication for echo before any surgery. Mandatory, dyspnea of unknown origin, heart failure patient, maybe, history of LV dysfunction. Indication for ECG before any surgery. Mandatory, ischemic heart disease, arrhythmia, peripheral arterial disease, cerebrovascular disease, structural heart disease, maybe, major surgery in asymptomatic patient with no history of CAD. When should echo not performed before any surgery? As routine investigation. When should ECG not performed before any surgery? In asymptomatic patient with low-risk surgical procedure. Validity for any investigation is for how long? 2 months. AHA guidelines for optimization and risk stratification in cardiac diseases. Step 1. High-risk surgery, like emergency, or time-sensitive surgery, proceed for surgery with high risk. AHA guidelines for optimization and risk stratification in cardiac diseases. Step 2. For elective surgery, do not proceed if following present. 1. Acute coronary syndrome. 2. Decompensated heart failure. 3. Significant arrhythmia. 4. Valvular heart disease. AHA guidelines for optimization and risk stratification in cardiac diseases. Step 3. Calculate perioperative risk of mortality by checking various parameters. Parameters: high-risk surgery, IHD, CCF, DM, creatinine greater than 2, cerebrovascular accident. Proceed if risk less than 1%. AHA guidelines for optimization and risk stratification in cardiac diseases. Step 4. Assess functional capacity by METs. Metabolic equivalent. Proceed if greater than 4 METs. What's METs? Amount of oxygen consumed by 70 kg person at rest. 1 METs equals 3.5 milliliters kilogram min. AHA guidelines for optimization and risk stratification in cardiac diseases. Step 5. Stress testing with dobutamine. Canadian guidelines for optimization and risk stratification in cardiac disease. Step 1 to 3 same. Step 4 BNP less than 92. Pro-BNP less than 300. Measure troponin levels daily till 3 days after surgery. Do ECG after surgery. AHA guidelines for surgery in patient with drug-eluting stent. Elective surgery wait 6 month. Time sensitive, Plan B W 3 to 6 month. AHA guidelines for surgery in patient with bare metal stent. Elective surgery, wait 1 month. Time sensitive, Plan B W 3 to 6 months. Indication for infective endocarditis prophylaxis in cardiac patients undergoing any surgery. History of IE, prosthetic valve, unrepaired cyanotic heart disease, repaired CHD with residual defect, cardiac transplant. How long should we wait to perform surgery in patient with URTI/LRTI? 2 to 3 weeks. Indication for pulmonary function test before surgery. 1. In restrictive lung diseases, silicosis, asbestosis. 2. In lung surgeries, lobectomy, pneumonectomy. Important risk factors for post-operative pulmonary complications. 1. Albumin concentration less than 3.5 grams per deciliter. 2. Aortic aneurysm repair. 3. Upper abdominal surgery. 4. Emergency surgery. ARISCAT scoring for respiratory risk in patient interpretation values. Low risk if value less than 26. High risk if value greater than 45. Elective surgery after a cerebrovascular accident can be performed after how much time? 9 months and keep aspirin continued. Which pre-anesthetic medication is given to relieve anxiety and provide sedation? Short-acting benzodiazepines. Which pre-anesthetic medication is given to reduce secretion? Anticholinergic agent atropine, glycopyrrolate, but only in children, mentally ill, or in head and neck surgery. For how long fasting is recommended prior to elective surgery? 6 to 8 hours. For how long fasting is recommended prior to elective surgery in children? Clear fluid 2 hours, breast milk 4 hours, non-human milk 6 hours, fatty meal 8 hours, solids 6 hours. What steps can be done to prevent food aspiration in emergency surgery? 1. Ing tube aspiration. 2. Prokinetic agent to increase stomach motility. 3. PPI to decrease acidity. Antibiotics should be administered how long before surgery? 30. Which pre-anesthetic medication is given to relieve nausea vomit? Ondansetron, but it's given only to high-risk category. Female, non-smoker, history of post-op vomit, history of OPIO. Which criteria define high-risk patients which need antiemetic ondansetron before surgery? APFL score. Side effect of antiemetic drug ondansetron. It's 5-HT3 blocker. Causes arrhythmia due to prolonged QT. Which analgesic is given before surgery so as to decrease post-op pain? Short-acting OPIODs fentanyl.